Hello, we are from the small group discussion of B7. At this moment, we will present and explain to you about the adenoid hypertrophy. And for more information, please watch this video until the last part.
Adenoid hypertrophy is an enlargement of the adenoid causing obstruction to the upper respiratory tract. So this could actually happen due to many reasons, for example, infectious or non-infectious diseases. For this disease, it was most commonly found in children, especially in children below the age of 5. The symptoms itself are usually not found, but then if it gets worse, then sleep apnea, dyspnea, and others could actually be found. Since it is also asymptomatic, usually it is not much detected, and it will get better as the child gets older. For the treatment itself is self-limiting, but then if there were complications to be found, then adenoidectomy can be done by surgeons. And for this reason, because not much is known, then further literature review needs to be more in-depthly discussed.
Hello, my name is Putu Asweni Pururaswini Astawa and my last 3-digit number is 161. So there is the problem formulation, like what is the definition of adenoid hypertrophy, what are the risk factors, signs and symptoms, how is the epidemiology, pathophysiology, management and prognosis, and how to diagnose adenoid hypertrophy. The general purpose is to know general information about adenoid hypertrophy. And there are also specific purpose. They are to understanding definition, epidemiology, pathophysiology, risk factor, sign and symptom, diagnosis, management, and prognosis of adenoid hypertrophy. There were two benefits of this project, theoretical and practical. The theoretical benefit of this project is to enhancing knowledge for improved clinical guidelines, to informing future research, to raising awareness among healthcare providers and the public, and etc. The practical benefits of this project include improved diagnostic tools and management strategies, better patient care and outcomes, enhanced training for healthcare providers, and etc. Thank you.
My name is Beninkinan Kalisa with last 3 digits of my student ID number R152. I will explain about the definition of adenoid hypertrophy. So, adenoid hypertrophy refers to the abnormal enlargement or overgrowth of the adenoid tissue. This condition is linked to mechanical obstruction and or chronic inflammatory process in the nasopharynx. The adenoid plays a role in the immune system by capturing pathogens that enter through the nose and mouth, particularly in childhood. When enlarged, adenoid hypertrophy can lead to various local, nose and ears, and systemic effects. Enlarged adenoid can cause issues such as nasal obstruction, mouth breathing due to blocked nasal passage, snoring, sleep apnea, and recurrent ear infection, as they may obstruct the eustachian tubes, resulting in fluid accumulation and ear infection. While the adenoid typically shrink during adolescence, children aged 1 to 6 years are most frequently affected by adenoid-related disease and condition. However, adults can also experience this issue.
I'm Angelica Fatma Angawan with your last student registration digit number 092, and I will explain the epidemiology of adenoid hypertrophy. Adenoid hypertrophy, characterized by abnormal enlargement of the adenoids, is primarily observed in children, with studies indicating a 64% prevalence in those aged 2 to 6 years old. It is less common in adults due to the natural shrinking of adenoids after childhood. There are slight gender differences, with a higher occurrences in males. Geographically, it is more prevalent in urban areas due to pollutants and allergens, and socioeconomic factors also play a role, with higher rates in children from lower income backgrounds due to increased environmental toxins and limited healthcare access. Temporal trends show a decline in prevalence in areas with improved air quality.
Greetings, doctors. My name is Janice Geraldine with last three-digit number 119, and for this project, I would like to explain about the pathophysiology of adenoid hypertrophy. So, the pathophysiology of AH involves a complex interplay of immune responses, genetic factors, and environmental influences. Immunologically, children with AH often exhibit altered cytokine production, particularly here is elevated levels of pro-inflammatory cytokines like interleukin or IL-32, which may contribute to the inflammation and further tissue enlargements. So this inflammatory response is frequently triggered by recurrent viral and bacterial infections, including pathogens like adenovirus or Streptococcus pneumoniae. Additionally, environmental factors such as allergies and exposure to irritants can exacerbate the condition by inducing similar inflammatory pathways. The disruption of the balance between adenoid's natural flora and the immune system can lead to chronic infections, resulting in a vicious cycle of inflammation and hypertrophy. Over time, chronic inflammation may cause structural changes in the adenoids, including metaplasia into multilayered squamous epithelium, which we know diminishes their ability to function effectively in immune defense. As children age, adenoids typically atrophy. However, persistent hypertrophy can lead to significant complications if not addressed through appropriate medical or surgical interventions.
Thank you for the opportunity. My name is Putu Chintya Harum Rahcetag with the last digit of student ID is 018. So now I will present about the risk factor of adenoid hypertrophy. There are several risk factors such as age that common in child under 5, then rhinitis allergy by inducing inflammatory mediator, then exposure like pollution, cigarette smoke, pathogen, and gastric juice, and also hereditary. That this condition can run in family. That's all from me. It will continue.
My name is Elisa Sinthya Dewi with the last three digits student number of 223. At this moment, I will explain to you about the signs and symptoms of adenoid hypertrophy. So pathologically, adenoid hypertrophy appears as a process of reproliferations of rigous tissue and associated with chronic inflammations. And some risk factors known for symptomatic adenoid hypertrophy are infections in head, ears, and throats, including cigarette smoke exposure, chronic sinusitis and tonsillitis, and allergic conditions. Patients with adenoid hypertrophy often have a variety of complaints and symptoms, but the most common symptoms is preceded by nasal airway obstructions. It happens because in adenoid hypertrophy cases, adenoid may enlarge, sufficiently blocking the airway, the airflow through nasal passages, and induce primarily mouth breathing, also affecting vocal pitch and tones. Inflamed and enlarged adenoid, usually covered by a mucopurulent discharge, which characterized by a flow of secretes running down to the back of pharynx. And this nasal airway obstructions then may causing chronic rhinorrhea, bad breath, difficulty eating, excessive saliva productions, toneless voice, snoring, and even sleep-disordered breathing in children. Nasal obstructions may also lead patients to experience sinusitis and facial pain or pressure, which characterized by high arch heart palate, increased facial height, and midface protrusions. Given that adenoid hypertrophy is related to the middle ear, nose, and paranasal sinuses, hence the clinical evaluation of adenoid hypertrophy needs to be based on a comprehensive otolaryngological examinations. Maybe that's all from me. Thank you.
Hello everyone, my name is Gabriella with the last three digits of my student number 081. I'm going to talk about diagnosis of adenoid hypertrophy. We need to do anamnesis and physical examination to establish the diagnosis. For anamnesis, patient will complain of facial pain, rhinorrhea, difficulty breathing through nose, sleep disturbance, apnea at night, recurring respiratory infection, hearing impairment, and some allergic symptoms. And for physical examination, patient will have adenoid facies, in which patient mouth is permanently open and the tongue is exposed. In addition, patient will often have eczema on the tip of the nose and breathing through mouth. That's all from me. Thank you.
Gusti Agung Krisania Mahaputri with last three digits of student number R143 will continue with workup diagnosis of adenoid hypertrophy. Adenoid hypertrophy is diagnosed through anamnesis and physical examination. For further assessment, rhinoscopy, bilateral automicroscopy, and fiber optic nasopharyngoscopy are commonly suggested. with the latter being preferred due to its reliability and lack of radiation exposure. Symptoms associated with adenoid hypertrophy include eczema in the nasal entrance, malocclusion, lymph node enlargement, a high palate, and dental malpositions. Nasal endoscopy may be performed before surgery to distinguish adenoid hypertrophy from other conditions like adenoiditis and rhinosinusitis. The condition is linked to immune system alteration, especially in cytokine production. Increased interleukin or IL-32 levels may play a role by inducing inflammation and promoting pro-inflammatory cytokines. Elevated markers such as IL-1, TNF-alpha, interferon gamma are also found in patients, while pediatric cases may show changes in lymphocyte population associated with obstructive sleep apnea. That's all from me. Thank you. Student number ID is 098. So I will explain about the management of adenoid hypertrophy. For the conservative management, for patients with adenoid hyperplasia without any other symptom, a wait-and-see approach is a possible option. There is some evidence that off-label intranasal corticosteroid may be beneficial for this patient. Additionally, conservative management should be carefully considered for patients with relative contraindication, such as submucous cleft palate or bleeding diathesis. There is not enough evidence to recommend using systemic steroids, antibiotic, or antihistamine for adenoid hypertrophy. Antibiotics are typically the initial treatment for acute and chronic adenoid infection. Amoxicillin is commonly used, but clindamycin or azithromycin is an alternative for penicillin allergic patients. Beta-lactam inhibitor should be considered for chronic or recurrent infection. Next is the surgical management. Adenoidectomy is considered for patients with severe symptoms such as recurrent infection, persistent ear condition, and or ineffective conservative treatments. Patients with chronic serous or mucoid otitis media often undergo adenoidectomy in conjunction with myringotomy and or tube replacement. For patients with a preoperative diagnosis of submucous cleft palate, the decision to proceed with surgery must be made carefully in collaboration with specialists in oral and maxillofacial surgery, podiatric, and pediatric audiology. That's all from me. Thank you.
Okay, we'll continue. My name is Putu Pranadea Vidya Sagara with the last 3 digits of my student number are 059. And now I will explain about the prognosis of adenoid hypertrophy. So the prognosis of adenoid hypertrophy can be improved through early diagnosis and proper treatment. Although adenoid hypertrophy is known as a self-limiting condition that will improve with age in adolescence and can even become adenoid atrophy, surgical procedures should still be performed on patients considering that complications from this condition have a serious impact on the patient's quality of life. There are 2 recommended surgical management for adenoid removal, namely adenotonsillectomy and adenoidectomy. In the United States in 2006, it was even recorded that 129,540 adenoidectomy and 506,778 adenotonsillectomy were performed in a year.
Hello, doctor. Let me introduce myself. My name is Michael Jonathan Raya with last student ID number 182. I'm going to talk about the conclusion. And adenoid hypertrophy is the abnormal expansion of the adenoid tissue, which can lead to nasal blockage, mouth breathing, snoring, and recurrent ear infections, especially in youngsters. Pollution, passive smoking, and recurring illnesses all contribute substantially to its development. Clinical symptoms and a physical examination are used to make the diagnosis, which is frequently confirmed with imaging or endoscopy. Conservative therapies such as antibiotics and nasal steroids may be used, but severe or chronic situations should be treated surgically, and early detection and suitable therapy can improve the prognosis and quality of life of the patient. And that's all from me. Thank you.